You're rolling.
All right.
We're rolling.
Rolling, rolling, rolling. Keep those doggies rolling.
I don't cut that out, Tyler. I want this in there.
No, cut that out.
No, don't cut that out.
Well, hello, and welcome to the 27th Degree with Chris and Nancy. For today's podcast, Nancy and I will be discussing the healthcare crisis. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare. Hearing healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit the website duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. All right, so let's start with, this is a topic that I'm very passionate about.
You are.
It's the healthcare crisis, and maybe many of our viewers don't know that we are in a healthcare crisis. But many, I suspect, have
I think many feel the
felt
impact of it and don't realize the bandwidth of it.
Right, and I think that's probably the case. So I want to break it down a little bit and talk about what we're dealing with. I mean, we're in the trenches, so we see this all the time. And I think that patients see some of it, they experience some of it, but they may not be aware of the scope of what's going on right now.
Why things are happening.
And why things are happening. And we're going to talk a little bit about that because this is something that concerns me greatly and concerns a lot of my colleagues, and it clearly impacts patients too. So
I could tell when you first brought this topic up, you were like, we need to talk about this. This is happening. It's very frustrating.
Yeah.
I don't think people are aware of this. And I'm like, yeah, let's just dive into this. So what are you feeling differently as a physician that?
Right. And I think there's been a dramatic change over, I've been in practice for 25 years. Medicine 25 years ago was very different, but I think that there's been a really dramatic change since probably around COVID. Since COVID started, and we'll talk a little bit about that. And it's not all, COVID is not to blame for everything, but talk a little bit about what I have noticed. You can probably break it down into 4 or 5 different reasons that we are having issues now, and we'll talk about what the issues are. But there's problems with the workforce, and I'm talking about not only our support staff, but physicians also, nurses. There's difficulty with we don't have enough bodies, and we'll talk about why that is. There's insurance costs, which directly affects employers and affects patients, of course. And there's unavailability of a lot of drugs, which has never happened before and is such an issue now. And the cost of drugs, of course, also. So let's break it down and talk a little bit about what's going on. Why don't we start with the workforce? Because I think a lot of patients don't understand really what's going on and how this is going to affect healthcare probably in the next, 5 years or so.
Right.
Okay. So a lot of my colleagues are my age. And, I plan on working for a while longer. I have no thoughts of retiring, but many of the doctors I've worked with did leave around when COVID was at its peak.
Right.
And I'm sure it happened with nurses too. I know it did. And as a nurse, you probably saw a lot of this.
There was a big exodus.
Right. So, why is that? Why did that happen? And there's a number of reasons for it. And it wasn't all COVID, but there definitely were concerns around the time that COVID peaked about, a lot of physicians and nurses had concerns about their health, and many left the workforce for that reason. But, I think there was a lot of burnout too. Mm-hmm. Okay. And, we were all working incredibly hard with, it seemed, limited resources. And as time went on, more and more of our colleagues were dropping out.
Right.
And we found ourselves working harder, probably harder than we've ever worked. I know harder than we've ever
Right.
worked. I'm working harder now than I ever worked in my life.
Right.
And, you know, what we're seeing, for example, from the physician standpoint is that there are a lot of physicians that probably would have worked another 5 years, 6 years, 7 years, 8 years who left. They were concerned about their health. They saw some of their colleagues get very ill, in some instances die from COVID. But beyond that, I think they were just frustrated with the whole system, how everything was approached, how they had limited resources. I mean, in the beginning, we didn't have masks. We didn't have any of the protective equipment that we needed, which is, you know, it really is crazy if you think about it. You know, we're in the United States of America, and we don't have protective gear for our providers.
I think that's one of my fundamental thoughts that gets me so frustrated is we're in America. We have such rich resources that could be available.
Right.
And it just seems like crazy. I know it's a complex problem to solve, but it just seems like we could be doing so much better,
Right.
especially when you look at national outcomes
Right.
for certain things.
Right.
And we spend so much money on healthcare, but our outcomes are not where they should be compared to other countries in the world.
Yeah, that's a whole other issue too, and I don't know if we'll have time to get into that. But if you look at, if you do look at our outcomes as far as, you know, child illness, deaths, longevity, all of that, you would think we would do much better than we do, but we really don't. You know, I remember, you know, years back, it was interesting when people would talk about national health care. They'd say, but just look at Canada. I mean, they can't, if they want to get a knee replacement, they have to wait a year, and they have to do this and they have to do that. And they're coming over the border to get things done. Well, they're not doing that anymore because our citizens are waiting a year, you know. And, you know, we are basically paying a premium for insurance, but we're in a situation where we can't even get the health care in many instances that we need. And that was never the case. You know, I think that citizens of the U.S. were willing to pay health insurance when they knew they had the best health insurance. They perceived the best health insurance in the world. They could get what they wanted, what they needed, but it's not that way anymore.
No, and I think what you said is also true. There's a whole other podcast, multiple series podcasts we could do on inequality in healthcare.
Right.
But just specifically, what are your frustrations as a physician? What do you see again day after day after day that you're like, this doesn't have to be like this?
Yeah. I mean, there's a lot. And I'm going to go through this, and I think somewhat of an organized manner, I hope. So that makes sense. But so let's just talk about the workforce issues. So we've talked about physicians. Nurses are kind of in the same boat.
Definitely.
A lot of nurses left. There's a lot of inequity I see with how nurses are compensated. I mean, during COVID, we had these, you know, travel nurses, which thank God we had them. They're kind of hired guns that came into areas where there weren't enough salaried nurses. And they basically filled a gap. However, you know, many of these travel nurses were getting paid, you know, a great amount more than what people who had been there 20 years were getting.
Yeah.
And that left a really bad taste in people's mouths. And I know a lot of nurses had issues with that.
I'm just going to say one thing about that too. As an organization, you only bring in travel nurses because you are paying a premium price for them. Right. You are only bringing them in dire circumstances.
Oh, I know it's out of desperation.
So these people are coming in and working under horrendous circumstances to begin with as well. So,
but as were the people who have been there 20 years.
Absolutely.
You know?
Absolutely.
And, you know, everyone talks about salaries, and, you know, people come in there and they say, hey, I'm getting this much money per hour. And then someone who's been there for a long, long time says, wait, I'm getting 40% less or 25% less or whatever it may be. And then that doesn't always sit well.
People definitely feel that. And there's so many things you can say about that when you look at what you can pay as an organization to stay financially stable for salaries, and just it's a really complex problem.
It is. I mean, there's no doubt that it was necessary, right? I mean, hospitals didn't have full staffing because they lost a lot of nurses and they
Yeah.
lost a lot of physicians. So you do what you have to do to keep things going and keep the organization going and take care of patients. And unfortunately, if you're a company that, well, not unfortunately for them, but if you're a company that provides travel nurses and travel docs, you know that you can get a premium and you're going to get that premium.
Right.
But then there's a backlash down the road that affects the organization long term because now you have a lot of disheartened long-term employees.
Yeah, and I think you're right. And I think what happens too, Dr. Junkus, is, there's a lot of recruitment efforts, and you're
Right.
almost coming into the same type of scenario with that. You're doing sign-on bonuses, you're doing all these recruitment efforts. But this poor nurse who's been there 20 years and working the off shifts or rotating shifts or whatever, what are they getting to compensate?
Right. And what some
with all
organizations
this?
did is they tried to match that, but financially that was not possible for many
Yeah.
organizations because they just didn't have the money to do so.
Yeah. And I think there's more options nowadays too. You had benchmark COVID as kind of where this became
Right.
really on the forefront,
Right.
right? People working from home and doing a lot of things that they hadn't thought of before too. So
Right.
many people left that typical bedside nursing, if we're talking about nursing, for instance, right? Or they're not going into the nursing programs. So there is this great shortage, but hey, guess what? There's also a shortage of nursing instructors.
Right.
So, even the programs that are accepting kids into a nursing program, they can still only accept X amount of kids. And now I've heard recently that your grade point average has to be a 3.8 to be kind of considered for a nursing program. So like nothing has loosened up. It has even maybe gotten even tighter.
Right.
But what's going to happen to you and I when we need someone to take care of us?
Well, one of the problems is, I do some teaching for one of the medical schools in the area, and I have medical students come in to my office. I'm one of the community educators, and I haven't had really one student lately that I can recall that was definitively wanted to go into primary care. They all seem to want to do, and I've talked to other colleagues who teach also who say the same. They want to go into specialties or they want to do shift work. And by that, I would mean either, hospitalist type work or, ER type jobs, where they're on so many days and they're off so many days and
They don't carry a panel.
they don't have to go home with a pager and be responsible, although you're always responsible for the patients you take care of, but it's different. So, once again, getting back to the whole travel nurse and locum tenens physicians, thank God we have them because a lot of hospitals would have shut down, a lot of nursing homes would have shut down, and we were able to continue to provide care in what probably was seamless appearing to patients out there. But there is that backlash down the road and that frustration that I think the longstanding staff feel when they know that someone comes in and to fill a gap and they're getting a lot more compensation. And a lot of these organizations really couldn't bring their employees that had been there for a long time, whether it be nurses or doctors, to another level because they were, there wasn't that much available money.
And to be clear on this, it's not just nurses and doctors. Like we're seeing this with all the ancillary staff, to your point.
Right. So that's the whole second part. So the first part, you got the nurses and the physicians, right? The clinicians, basically. And then after that, you've got all your support staff, phlebotomists, medical secretaries, medical assistants. And what we've seen with this is that there's been a real lack of qualified staff. Not to say they're not out there, but we used to get, so many CVs, resumes a week that it was, if you needed a new staff, it was pretty easy to find one, quite frankly. You take a pile and you'd have 20 people to call. It's not that way now. And the other thing that's happened during this whole period is that the salaries have progressively gone up regularly. I raise the salaries almost every 6 months of my staff in my office. And it gets very hard to do that. There's a point where there's kind of a breaking point where you just it's hard to do. We're trying to bring people up to a living wage. We want them to get compensated fairly. We want to be competitive with other organizations, but everything went crazy during COVID.
Yeah.
Things got more expensive. Nothing has gone down in price. This is all related to that, and as in medicine is not unique. I think that everyone out there is suffering in that they're feeling how expensive everything is. So you have to, as an employer, you have to make it so that people can live and get a reasonable wage, right? But then every employer out there knows this. You do that, but then somehow the money has to come in, and it becomes more and more difficult as you keep raising these salaries.
I was just going to ask you that. Is there anything to balance that on the reimbursement side? Like, did reimbursement rates increase, or are you kind of where you were a couple of years ago?
So reimbursement rates, they may change a little bit. They don't change dramatically. I mean, if you look at, for example, nursing homes, and this is something a lot of people don't know, but most of the long-term patients in nursing homes are Mass Health patients in Massachusetts, right? In Rhode Island, to be Rhode Island Medicaid. After you're in there for a while and you've depleted all of your resources, you end up on a Mass Health type program.
Even our area hospitals are 70-30 Medicare, Medicaid mix.
Right. And so with Mass Health, which is basically, Medicaid, these facilities don't get enough compensation to support their efforts. So why did nursing homes go into doing short-term rehab? There's a couple reasons for that. One is that we were trying to get patients out of the hospital because hospital care is very expensive. Nursing home care is less. But the other reason is that nursing homes very quickly realized that they couldn't survive on what they got on their long-term care patients. And there are some nursing homes, in fact, that have decided not to do long-term care, and they just do rehab now. I go to a facility I've been going to for 25 years. I'm very proud of, and we have a very dedicated Alzheimer's unit, and 90% of our patients are long-term care patients. And I'm proud of the fact that we've been able to do that. But that's not the way that a lot of homes have gone. A lot have decided to get rid of their dementia units and just do rehab because that's how they can make money to support the facility. It's very, very hard to support a facility on long-term care patients on what you get. So that's an interesting point. So there's some compensation issues, and then there's this disparity that even though we talked about all these struggles and this and that, and how hospitals are struggling, nursing homes are struggling, staffing costs are up. You have these outrageous salaries that these CEOs of insurance companies are getting. And I'm sorry, no one's job is worth what these people are getting, okay? And I just pulled off the internet. This is public knowledge, so I know I'm not going to get sued for it. And I'm not going to mention who the insurance companies are, but there are three big ones. And here's number one, number two, and number three, this was in 2022, because there's always obviously a lag with data. So number one made $22.1 million per year.
Wow.
Number two, CEO, made $21 million, and number three made $20.9 million. And this is all public knowledge.
So what's interesting about that too?
Mm-hmm.
That's strictly salary. That doesn't include benefits. And
some of this included stock options and things, but that is what they are getting in compensation. It may be broken down, and you can read about what they're getting in which category, but I still think it's just an outrageous amount of money for, an executive to get. And I also think that football players shouldn't get what they get. And, a lot of this stuff trickles down.
I think when you see this, again, you used a great word. There's disparity here because there are people that are greatly impacted in how limited they are through the insurance companies.
So if you look at the top three, right, and you look at what their salaried employees in these insurance companies make, so they are getting 277 times the average employee, 331 times the average employee, and even with that, they're getting on average a pay bump every year of at least 10%, some less, but the number three on the list got a 13% pay bump, even though they were at $20.9 million.
Oh my God.
So this is frustrating. I mean, this is an outrageous salary and I'm not saying if they didn't get it that, our insurance costs would go down, but you have to understand that this is part of why insurance is as expensive as it is. Absolutely. So it's a concern. And I'm sure everyone out there has felt the cost of their insurance going up every single year. And I hope,
especially now,
right.
It's open enrollment for so
Right,
many places.
right. And I'm sure everyone out there realizes that, hopefully they're in a situation where they're paying a percentage and their employer is paying a percentage, but that's also more stress on employers. So there's this trickle-down effect that affects patients, it affects the healthcare system, it affects employers out in the community. And I can also tell you that it is very rare. I've never seen it happen. I'm waiting for the day it happens. That, that actually the cost of insurance will go down one year. It doesn't matter how much money they make. It goes up every single year.
It's going to go down.
And then it gets pushed to us, right? And there may be some instances where it went down a little bit, but I don't personally know of that. So I don't think it happens because I pay a good percentage of the cost for my staff. And every year I pay more. So I mean, I think that's a great concern.
Oh, definitely, because there's no end to it. There's no cap to it.
There's no cap.
And they have such a strong lobby group as well.
They have a very strong lobby group. And it's like the government, right? The government has an open checkbook, right? Like you run your house and you get a certain amount of money that comes in. I get a certain amount of money that comes in. And then I talk to my wife and you talk to your husband about, can we afford this, this big ticket item, whether it be a car or whatever. You set aside money for your mortgage, for your food, for, whatever you need. And then you decide those things, right? If you don't have enough money, what do? You
go without.
You go without or you get another job, right? But the government is very different, aren't they? They basically, what do? They increase taxes. So, we end up in a situation where we just pay more and more all the time.
And there's no end.
And there's no end. And, and things are really getting more expensive. And I think that everyone out there is really feeling the squeeze. Gas has gone up. Food costs have gone up. And we all said, oh, it's from COVID. Transportation issues, supply chain. Did it go down?
No.
The supply chain issue, I think, is fixed, but it never went down. These prices have stayed as they were.
You know what happens too, and again, this goes to disparity and healthcare inequity. Yeah. But it seems like the people that have money,
right,
are okay with their healthcare choices, and the people that are on government programs, get covered for necessities. But those like blue collar workers that are like really struggling, pulling down like 2 jobs or what have you, single moms,
just to have food on the table.
Right. I mean, their healthcare costs are crazy.
It's crazy. And then there's, a lot of my patients, they don't take their meds as they should because they can't afford them. So they're taking them every other day.
And then they're termed non-compliant.
And then they end up in the hospital because they get sick. Some of my elderly patients, have difficulty affording food. I have patients now who I've never seen this before, but over the last couple of years now are really fearful that they're going to be homeless. These are people who are working, 40 or more hours a week, and they may become homeless because things are so expensive. I mean, this is a real problem with our society.
Yeah, I agree.
It really is. So,
on that happy note.
So we talked about the workforce, physicians, nurses. We talked about staff. We talked about insurance companies. We talked about insurance costs, and we talked a little bit about loss of physicians. And I'm really concerned about this because I do think over the next few years we're going to find that there just aren't enough of us working.
Well, even now, it's really hard to get a primary care physician sometimes. Yep. Like no one's taking new patients, or you have to look for a long time to get a primary care physician in the area that we're in.
Right.
Unless they're brand new and you find out about it and they go into a practice that happens to be in your network. Great.
Right.
But if not, what do you do?
Yeah. I mean,
I know so many people that don't even have a primary care physician, that
Yeah.
I'm healthy and I'll just go with this for a while, you
Yeah.
know? But then it still takes 3 months to get in. And then if you need a
Yeah.
specialist,
if you're lucky,
yeah,
3 months.
yeah,
I mean, and not having a doc is good until it's not good, because
right,
then you have a crisis that comes up, and you have no one to kind of navigate you through that crisis.
right. And then you're talking about the healthcare resource
Mhm.
utilization of going into the ER,
Right.
and that creates bottlenecks
Right.
too.
But I am very concerned that over the next few years, we're just not going to have enough primary care docs. I don't think there's, I think there's the number of physicians graduating from med school, going into residencies, who are thinking, I want to be a primary care doctor, is low. And
So what's the discussion? Like, what kind of conversations have you been involved in to kind of problem solve?
well, when I see the students, I mean, I show them obviously all of the really great positive things about primary care. And there are a lot of great positive things. That's why I'm still doing it. And, I mean, hopefully they don't focus on the frustrating things that we deal with. But, it is it is a career where you can have these long-term relationships with people, 25, 30, 35
Right.
years, which you really can't do in really almost any other field. I mean, surgeons may see someone a couple times, ER docs will see people come in periodically, but it's different. I mean, I'm seeing a lot of these people, 4 times a year,
Right.
sometimes more, 4 times a year for their chronic medical illnesses or issues, if they have hypertension and diabetes, but they may come in between for a sick visit. So that's a great thing about primary care, and then, like I got a letter the other day from, I took care of a patient for probably 24, 23 years. And then she was older and passed on, and her daughter sent this really nice card thanking me and the staff and my medical assistant. And those are the things you really hold on to, because you may see that in other fields, but I think primary care is unique for that. Okay. But what is frustrating now, and why are people not going into it? I think there's probably 3 reasons. And I'm not going to focus too much on the first one, because honestly, I think I get compensated fine, but there's definitely a disparity in compensation between primary care and some other fields. But the second thing is the absolute enormous amount of paperwork that we are now required to do. And it has increased every single year. It started with Obama, and it has just gotten worse. And
Even with the healthcare records, it's not like easier or streamlined
no, I mean, I
with the
think
electronic healthcare record.
I don't think it's, I mean, unless you start using artificial intelligence to do your notes, which some people are starting to do now, which is a really fascinating concept. I mean, we spend a lot of our time doing record production, producing these records that we need, so that, 1, we can remember what we did with the physician, with the patient. 2, we can coordinate care with other physicians. But there's a whole medical legal reason behind it that requires a ton of documentation that physicians 40 years ago didn't really worry about as much.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So if I see you as a patient in the office and you're tapping away on your computer when I'm in the room now, that's what you have to do.
Right.
Are you still involved in my record after I leave you?
It depends. I think that most providers probably don't get the note done during the visit.
Right.
So they have to go back and finish it up and clean it up a
Right.
little bit and that. But, let's say a visit is a 20-minute visit. I can guarantee you that at least 10 minutes of that visit is documentation. So you're really not seeing the provider for 20 minutes. And that 20 minutes is generous these days.
Right.
So what's happened is the time that you are able to spend with your patients has been compressed. And that's because overhead is high, and you need to do what you need to do to support the staff. There's a lot of reasons for that, and we don't need to get into it. And there's less doctors and more patients, but one of the enjoyable things about primary care has always been sitting there with your patient and spending some time with them.
Right.
And nowadays, there's very little of that. It is more of, you have a defined period of time, and you have to get things done in that defined period of time, including all the documentation. So, and then in between that, you've got, of course, the messages and the other paperwork that you need to do, which every year grows. So I think that's one major frustration for primary care physicians that are kind of pushing them out. It's probably the major one, quite honestly.
So then, I want to explore a topic too.
Yeah, and actually, we can explore this one a little more because I got some other examples I can give you that.
Yeah, so I want to talk about navigating the healthcare system, but just with going back to you, before we get into this, you had talked to me a little bit about how frustrating it is with insurance denials. Can you talk a little bit about that?
Right, that was the next thing I was going to get into, and kind of that gets into the whole paperwork aspect of it.
Yeah.
But so it used to be that physicians were trusted to make the right decisions in regards to ordering tests, and we would call a radiologist if we had a question, we'd order the right test. But a lot of these tests like MRIs and CAT scans and even ultrasounds, they cost a lot of money. So what a lot of insurance companies have done now is they've pretty much decided that they're going to deny a lot of what comes across their desk. I don't know the percentage, but a lot of it gets denied. And then the physician has the option to do what's called a peer-to-peer, which is, when you get on the phone, and all this stuff takes time. You get on the phone with a physician that is paid for by the insurance company. It's supposed to be a peer, which means if I'm a primary care doctor who has been trained in internal medicine, I should be speaking to a peer who is a primary care doctor, retired or not, who is trained in internal medicine. But sometimes I'll get a retired dermatologist or a retired general surgeon who knows absolutely nothing about what I am trying to achieve because they didn't do primary care.
Right.
But you spend 10, 15 minutes on the phone. And, in the past where after a discussion, you often they would do the reasonable thing, which would be to okay the test. Because we're not ordering tests needlessly. We're ordering for a reason.
Right.
Now it's like, no, they need this first. They need that first. And there's these hoops you have to jump through. Sometimes you can't even do a prior auth. They just will flat out deny the test and you can't get it.
So if I'm seeing you as a patient and you feel I need a CAT scan for some reason, and talk me through some denials that you.
I'll give you a recent one. Okay. I saw a patient. I examined him. He said, I have a lump under my arm. I felt in his axillae, his armpit. He had this very large mass, which I was concerned about. And I, was concerned obviously about cancer. When you feel something like that, that's the first thing that jumps into your mind as a physician, although there are benign causes. And I ordered a CAT scan to look at the area. And I also, I wanted to look at that area in his chest too, because sometimes a lot of this stuff comes from the chest. And shockingly, it got denied. So,
do they have to give you a reason for denial? Or is it just like this, red, denied?
They, yes and no. I mean, it's very vague. I mean, you really don't know the exact reason, quite honestly. Sometimes they'll tell you that you have to do step X, Y, and Z before, but you don't always get the answer you want. So that got denied. So then I went back and I said, well, what will they cover? It took a long time to get a response. And by the time the patient had an ultrasound, which was not the test I wanted to do, it was 3 months. Ultrasound shockingly was abnormal. I mean, you can feel this thing. He's got an orange under his armpit. Ultrasound, all it's going to tell me is whether it is solid or if it is fluid filled, like a cyst, right? Shockingly, it was grossly abnormal. And then the recommendation was do a CAT scan, which was what I wanted 3 months ago. So then now I have to once again go through the process of trying to get them to okay this. And I don't remember exactly if I had to talk to the physician again or if they just okayed it, but it got okayed. And
But
you know,
now you're like even further down the timeline.
You're 3.5 months out. If it's a cancer, that's 3.5 months that this thing's been growing.
And they are aggressive cancers.
In this particular case, fortunately, it turned out okay, but it was very, to me as a physician, and I'm sure to the patient, very concerning.
Very disturbing.
Now, I've read a lot of things on the internet, physicians talking about their experiences in other parts of the country. I think we're actually fortunate in Massachusetts because we have a lot of availability for many specialties, although patients are definitely waiting longer than they want. But you go to other parts of the country where they have incredibly limited resources. I read one article, doctor referred a patient to a dermatologist because of a concern. And the appointment was given for 18 months after the referral was made. And then at the, 17-month and 25th day mark, the office called and said, we need to reschedule you. We're going to reschedule. You're going to be good. We're going to do you a favor because I know you've been waiting 18 months. It'll only be 8 months now more.
Oh, no.
Yeah. So this stuff happens all the time. And we don't see it as much in Massachusetts, but throughout the country, this is not uncommon, to hear. And there are places where they don't have primary care docs enough to take care of patients, and it becomes an issue.
Is there an issue like if you're waiting a long time and your insurance denies it and you have the ability to pay cash, is that an option, or do people just say, no, sorry, you have to really go through your insurance?
I honestly, in my entire practice, which is fairly sizable, I have one patient who has the resources and is frustrated by the system, and he does that, but that's not common. And I would say that most people can't do that, and it would be
it's horrible that you even have to think
hard to expect them to do that. I mean, you're talking MRIs and CAT scans. These are expensive tests. So yes, you can pay out of pocket, but most people can't afford to do so.
Why do you think the denials have gone up?
It's a cost saving measure. I mean, I think the hope is that you make it frustrating enough, and maybe this is my thought. The insurance companies maybe could tell us differently. I'm sure they would say that they're trying to do it to provide, better quality and less expensive care. But, I'm not sure that's always the case. I think sometimes it's just, make it frustrating, and maybe patients go away, or maybe the doctors give up, that type of thing. So.
Our producer just sent us a really great article on a certain insurance company with the algorithm that they use to reject patients' health insurance claims.
Okay.
We'll put that in the show notes for people that want to read that.
Yeah, I think it'd be worthwhile looking at because, frankly, sometimes it's really hard to understand the rhyme or reason behind it, because sometimes it's not based on what they consider medical necessity. So. But we can put that link. I think that'd be very interesting for people to read about.
The gist here is bulk denials with no individual review. Yeah. So they're just, like you said, they're just really rubber stamping them with denials.
I mean, I've had recently, and this is odd, this is just this year, I've had this happen a couple of times. I've had denials for like low ticket items like x-rays.
Why?
I don't know. I mean, labs, like this is something I tell patients all the time. They come in, I want to get this lab, this lab, this lab, this lab. Okay, you have to have a diagnosis because they're not going to pay for it.
That happened with me. I was surprised because I was just worried about my sleep, and I had heard certain things if you get, see where you are with some certain lab work. And I'm like, oh, can you draw this on me and this on me, this on me? And they're like, oh, we'll have to like dig for a reason. Yeah. Because, I
mean, if there's not an appropriate reason, you just can't order it. Yeah. I mean, you can order it, but the patient may be responsible. Yeah. And some of these things are expensive. I get a lot of requests for, say, vitamin D levels and B12.
That was exactly it.
And, sometimes there's no real reason to order that, and you have to explain to the patient, and they get frustrated. They figure they pay insurance, they should be able to have it done.
So what if I'm a patient and you're like, and say I'm worried about something, say I have a lump and I don't want to wait all this time. Like what can I do? Have you seen like patients be successful with dealing with insurance agencies if they call up, or is it really you carry the weight as their PCP?
Well,
but can I fight a claim?
You can. And it falls to the physician 99% of the time, because a lot of patients don't understand how much power they have, and they're hesitant to make that call to the insurance company. So we end up fighting the battle for them. But yes, if you call your insurance company and you advocate for yourself, that goes a long way.
I just think it's so hard. I do a lot of visiting nurse, right? And one of my patients is very knowledgeable about the healthcare system.
Mm-hmm.
She had to go through chemotherapy and bone marrow transplant and all this stuff.
Mm-hmm.
And she had to navigate our healthcare system, which is very convoluted, very complex. You're feeling like hell. You're throwing up. And there's not even, and she was involved in a very good program out of Boston, but there's no one to stand beside her and navigate that healthcare system with her. I mean, we did many things together, but even as far as when she qualified for disability, getting that payment took 18 months. She actually ended up calling our state representative to help it with that. It was like crazy what you have to do and how hard it is to work through our system.
And though I say, there's a lot of power in patients advocating, to call an insurance company is also an incredibly frustrating process. I mean, you could be on the phone for hours.
2.5 hours each. I had to call for one of my patients. I had to call Medicaid. And actually, when I got them, they were very nice to deal with, but it was a 2.5 hour wait each consecutive day. And you're talking to multiple people and telling your story repeatedly over and over again.
And I'll tell you, it's not much different when our staff calls. Sometimes they are on the phone on hold for an hour with these companies trying to get one prior auth.
Right.
We have, lots of these that we have to do a day. Another example is, let's talk about medications. I mean, more and more medications aren't covered, right? We used to be able to call the pharmacy and say, Mrs. S, this med is not covered. What can she take? They won't tell you anymore. They don't know. The only way they know is if you put in a med and it gets denied, and then they can tell you if it's denied or if it goes through. So we can't even make those calls anymore.
Do you still get samples? Do you still get like some med samples?
I don't, because you have to basically treat your office as a pharmacy. You have to record the expiration dates, who you gave it to, if there's a recall on the lot.
Oh, so it's not simple. Like I was kind of thinking in my mind, here's some samples, doc.
No,
thanks.
it's not
Here
that
you
simple
go,
anymore.
patient
There's
Susie.
actually a lot of steps
So
and
it's
liability.
all documentation for that as well.
But medications have gotten really, really, really expensive. Less and less coverage for these medications, and that's a frustration. If you're a diabetic with hypertension, you could very easily be on 5 or 6 drugs, you know, and then throw in, some heart disease or high cholesterol.
Eliquis, right?
Yeah,
the cost
atrial
on that
fib,
is
whatever.
Crazy.
So, it's not infrequent for some of my older patients to be on. I mean, we try to limit them and give them only, try to keep the meds to a minimum, but they could be on 10 medications.
Right.
So, and then finally, it's not only the cost of drugs. What has become more frustrating to patients and to physicians is the availability of drugs.
So what's going on with that? Can you talk a little bit about that? Because why are drugs not available?
I got a sense, but I don't know if I know 100%. So this all, to me, started, we had that big hurricane that hit Puerto Rico. So there's a lot of drug production in Puerto Rico.
Oh.
And then there were some drugs that just weren't available for a while. But it's continued. And, that's not the issue, obviously, anymore. I think sometimes what happens is, especially with generic drugs, the margin, what they make is very slim. You might have 10, few companies that are competing to make a generic drug, and they're making their money on bulk. And frankly, I think they lose interest in making the drug sometimes because there's not money there. We've had problems with drugs being impure and having chemicals in them that are either cancer causing or there are other health concerns. So they get pulled off the market. We have prescription drugs, not generics, but name brand drugs that they have trouble finding components of the device. This happened with some of the diabetic drugs. They're basically a kind of a twist needle injection type thing, all in a, you don't have to draw anything up, but they had problems getting the parts for the device. They said supply chain was the issue. I don't know. Maybe it was, maybe it wasn't. But
And some drugs have multiple uses, and maybe, off FDA brand,
Yeah.
whatever, and
Yeah.
then that causes a shortage of the medications.
what'll
too.
happen sometimes is, and we had this happen with one of the really common blood pressure meds, and I don't know if it ever came back. It was one of the ACE inhibitors, not lisinopril, but one of the others. It wasn't available for whatever reason. It was generic, been available for a million years. I don't even know what the issue was. And then you get inundated. I think it was quinapril or acupril, one of the two. You get inundated with all of a sudden, you get all these notices from insurance companies because they know who's on the drug. It's not available. So one day you walk into your office and there are 55 faxes that these patients have to be switched over.
Oh my God.
And, so each one of those patients, you have to call. You can't just switch a med. You got to call. You got to tell them what's going on. Or you have the pharmacy call if they're nice enough to do it. Someone needs to call them. And then you switch it over to an
And the drugs
appropriate
may
med.
have different interactions with the slew of drugs that someone might already be on.
Sometimes, in this case, when we were talking about the ACE inhibitors, they're very similar in their side effect profile and how they function, so it wasn't an issue with that. But there are other times that there are drugs that we pick because they have a low side effect profile, and the pharmaceutical company has problem producing it, and we don't have anything that's as good, or the insurance company won't pay for it because it's more expensive and they want a lower cost drug that has a host of potential side effects. And we know that as physicians, and it concerns us. So, it's all become very difficult to practice.
So what's your recommendation, for patients? When they're trying to deal with all this stuff, great. I'm getting all my insurance. I'm getting denials. I can't afford my medication. Right. This medication isn't available.
Yep.
And they're feeling bad most of the time, right. Or they're concerned, or they're worried.
Yeah. First of all, don't be afraid to, talk to your doctor about it. We would love to, in the extra 30 seconds we have in the visit, commiserate about this stuff, because we should know what they're going through and they should know what we're going through, right? Because we have to work as a team. I think that patients should advocate for themselves as best they can. You can't rely on the office doing it 100%. It has to be a team effort. And that means you may need to call your insurance agent or insurance company, and talk to them about your concerns and your aggravation. You may need to call your politician. And, these companies have very strong lobbyists. So, you wonder how far that will get. But if enough people call, it does make a difference. I think that's important to do.
And sometimes if you have a really strong family advocate, like my patient who was very sick after the chemotherapy and the bone marrow transplant, right. She had a close relationship with her sister. So her sister would go to certain appointments with her and advocate for her and help her navigate some stuff. So don't be afraid to lean on other people, because I know people sometimes don't do that. They feel like they're going to impose on somebody.
So I don't want to be completely depressing during this talk. This is a crisis, and I want people to know it's a crisis, because I think many patients are somewhat insulated from what's really going on. So I want them to be aware, and many are aware because they've dealt with it.
Or they're
personally.
being impacted and they don't know why. They don't know the reasons.
But I do think there are things we can do. To sit there and kind of, just say, oh God, the sky's falling and there's nothing we can do, doesn't help. You can definitely advocate for yourself. You can call your insurance company. You can call your whatever elected official you have voted for, or whoever's in. You maybe you didn't vote for them, but they still have to, they're still your representative. These are things that can help.
I think, and be aware to your point with the political side of things, is be aware of what legislation's coming down the pike, and get out there and vote against it if it's not a good move.
I agree. I do think, and I've sent letters to politicians over the years. They do respond. They do listen to this. In their mind, and it's true, every vote counts. So I'm not saying that they're going to fix the problem, but they're going to listen. And if they get enough people, talking about the same thing, it will become a focus of what they look at. So I think it's crucial. And the last thing I'm going to bring up is the mental health crisis. Okay. And we could talk a whole
Are you sure you don't want to do this in a
hour on
separate
this, but
podcast?
I want people to understand what this is all about, because I don't think people understand what this is all about. So we have less and less people going into psychiatry. What we feel in primary care is probably minimal compared to what psychiatrists have experienced over the years. So they're kind of ahead of us in the curve. There's very few people going into psychiatry. There's very few available appointments. And whether it be for mental health or alcohol or drug addiction, whatever the concern is, the insurance companies expect a person who is already struggling to advocate for themselves and make that call to set up rehab or to do. Now, we help patients to get psychiatric appointments and that, but the drug and alcohol issue is more difficult, because if you're going to go to say, I'll say Star, we can call and say that Mrs. X will be calling, but they expect the patient to make that, to reach out.
Right.
And honestly, some of these patients have difficulty doing that because of what they're struggling with.
Right.
And I don't think it should fall completely on their shoulders. We are glad to assist, but at the end of the day, they want patients to make that call. They don't want us to do the work and not have the patient, follow up. And I think that's the issue, because there's limited resources. But it really makes it hard for the patients who are really struggling, who don't have the inner resources to be able to do that.
I think what's difficult with addiction too is you have a certain window where in your mind you're ready.
Yes.
Like right now, I'm ready. I feel like I can go and get myself treated for this. If that window passes, that's a lost opportunity, because
It is.
5 hours later you might feel totally different and succumb to your addiction again.
Yeah, you're right. It's very sad. I think it's very challenging. I mean, there's only so much we can do as primary care physicians. There are meds that are available now that weren't available years ago, but it's not just medication. Patients
Lifestyle changes.
They need support groups. They need often they're dual diagnosis, meaning they have an underlying psychiatric issue that needs to be addressed. And once again, we have limited resources for drug and alcohol addiction, and very limited psychiatric assistance out there, and counselors, same thing. So that's a really, really frustrating part of what my patients have to deal with. But I do think we can advocate as physicians, as nurses. I do think our patients can advocate for better resources and for better health care. And we should be doing that, because if we don't do that, we're going to end up waking up in 5 years and we're going to find that we're not going to have available what we need to have good health care.
And isn't it crazy too? You listen to some of these political debates that are going on right now.
Right.
And you feel as a medical person that healthcare should be on the forefront. And it's not.
It's not.
And you're like, we're going to implode as a country for certain reasons. And I don't know why that isn't on the agenda.
It should be. I mean, it should be a priority. And depending on the election, sometimes it is a priority, but it seems like it's taken a back seat.
Mm-hmm.
Yeah.
Mm-hmm.
Wow. We covered a lot.
We did. More to come.
Yeah, more to come. So anyway, I hope that everyone out there picked up some good points, enjoyed that. I don't want to depress everyone, but I do want you to know what's going on out there. So feel free to, contact us if you have questions. We'll try to help out as much as possible. I want to thank you all for listening to our show. If you'd like to become a sponsor, please contact us at 774-319-4230. Special thanks to my good friend Ron Gamache for all of our intro music, and BioSkills of the Northeast for producing our show. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit our website, duncanhearing.com. Thank you, everyone, and we'll see you again soon.
Bye now.